The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, welcome to Spinal Cord Injuries. Let's get started. Objectives. We're going to define the anatomy of the spinal cord and associated structures. We're going to discuss the central nervous system. We're going to identify the different incomplete spinal cord injuries and analyze a case study and apply it to core anatomy and physiology within this lecture. Let's start off with our case. We have a 14-year-old female patient. She is approximately 50 kilos. She was with her best friend and her brother. They were at their home swimming pool that they've had since she was a young kid, so this is not a new area for her. It was about 10 o'clock at night, and she dove into the pool. She hits the bottom of the pool. She comes up to the surface. She is floating face down and basically is noticed right in the nick of time by her brother, who rolls her over. She is stating that she can't move from her basically nipple line down. They access 911. She is transported to an LZ, and she is then assessed by the paramedic on scene. Current blood pressure of 98/62, pulse of 60, end tidal CO2 of 32. Flight crew gets on scene. They do a quick assessment. They find her on a long spine board. She does have a C-collar in place, and she is fully immobilized. She has a very flat affect, very kind of slow, sluggish to respond, almost seems a little stunned. She does have severe weakness in the upper extremities, able to somewhat move her hands, but is unable to make a good grip. No movement whatsoever in lower extremities, and with a pain response assessment is identified as having no response. So let's move on to really the anatomy and physiology and really break down the different levels of the spinal cord, the vertebral column, and we'll come back to this case in a little bit. When we think about the spinal cord, we know that it's protected inside the central canal and really lies inside the vertebral column. And when we look at the vertebral column, we have our different sections. So we have 5 sections. If we look at our cerebral vertebrae, we know we start at C1 and move to C7. So I always remembered it as 7, 12, 5, 5, 4. Remember that all the way back to EMT basic school, and have never forgot that. Now, we're going to see a little bit of a difference when we look specifically at our spinal nerves. There's a little bit of a difference, and we'll identify that here in a few slides. Cervical is, again, 7. We have our thoracic is going to be T1 through 12. And we have our lumbar, L1 through L5. Sacrum is another 5 little vertebrae, and then our coccyx. So when we consider that, how does that look from the spinal nerve standpoint? As you can see here from the spinal column, that your spinal nerves are a little different, and we have C1, which is really the head and neck, but we go all the way down to the hands, which you have a spinal nerve called C8, and that's the big difference in your spinal cord nerve innervation. Thoracic is going to be the same. We have T1 through T12, and then we have our 5 lumbar, 5 sacral, and then below that is our coccyx region. When we think about anything below really the lumbar area, that's where we get into what's called the conus medullaris. And the conus medullaris is really the tip or the ending of the spinal cord as we know it. And that, in most cases, terminates between L1 and L2. And everything below that is called cauda equina. And that is called a horse's tail. And those are all those little nerves that come off of the conus medullaris and feed down into our lower sacral and coccyx area. So we definitely can still have spinal cord injuries as low as our lower lumbar region. And you can see even in the sacral region, in this area right here, you can have injury that causes bowel, bladder, really sexual dysfunction, inability at those low levels. So spinal cord injuries are not just an area like we commonly think of high spinal cord, cervical, lumbar, or cervical thoracic, I should say. They can affect those lower regions. Now let's look at the ascending and descending tracts of the spinal cord. And so I want you to think of ascending tracts as white matter and descending tracts as your gray matter. Ascending tracts, again, white matter, are going to be myelinated cell bodies. And we're going to really dissect your axon dendrites and look at that in depth in a few minutes. Your gray matter, though, I want you to remember, are unmyelinated cell bodies. And so when we think about just from a high level, high optic view, I want you to think about white matter as ascending tracts. Ascending tracts are going to be sensory. Descending tracts are going to be motor information. Gray matter, you have, somatic and visceral, motor and sensory information that is moving up and down. But really, when we think about this from a high level, we have ascending tracts that is going to send information to the brain, and that's going to be sensory, where we have our gray matter is going to be more descending tracts, and that's going to be more of a motor neuron type of a tract. Now let's dive into the spinal cord and really look at this from an anatomy standpoint. And I first want to point out that we have our posterior gray horn, as you can see here. Posterior gray horns contain neurons that receive somatosensory information from the body, which is then transmitted via the ascending pathways to the brain. Remember, ascending pathways are going to primarily be our white matter. When we look at this from the anterior gray horn standpoint, anterior gray horns largely contain our motor neurons, and they exit the spinal cord to really hit on and innervate the skeletal muscles. And then lastly, the lateral gray horns. First, I want to point out lateral gray horns only come into play at a level at T1 down to L2. So everything above T1, you do not have lateral gray horns. And our lateral gray horns really contain neurons that innervate visceral and pelvic organs at a high level. So what we can say is that white matter, again, remember, our white matter is greatest at the highest level. So think of cervical, you have high white matter. And as you progress downward in those ascending tracts, it becomes less and less and less until you get down to the coccyx region. And then in contrast, when we think about gray matter is actually greatest at our lower levels, so greatest in the coccyx area. And as you move upward towards the brain, it gets smaller and smaller and smaller. That's where, again, you have dominant white matter. As I said, let's look at the axon, the dendrites, the myelin sheath, and really dissect how a nerve impulse works. As you can see here, we have our axon, and that's this area right here. And that axon is connected to a cell body, and that cell body has a nucleus, and off of that cell body, we have what's called dendrites. In the axon area, I want you to notice, this is the thing I remember back at A&P that I always loved and found very fascinating, is how does a nerve impulse move so rapidly? And a nerve impulse moves rapidly based on what's called a myelin sheath. And that myelin sheath, we have these little, I always think about a capsulated area over the axon, and the nerve impulse is allowed to jump over these little canyons. And so we're going to look at that again at more of a closer look here in a second, but that really allows for that nerve impulse to move very, very rapidly. And then at the end, that distal end, we have the axon terminals. Now let's look at the actual axon and myelin sheath of a myelinated and unmyelinated cell body. When we think about myelinated cell bodies, remember that's going to be white matter. Unmyelinated cell bodies will be gray matter. And that spot in between the myelin sheath is called the node of Ranvier. And that is that gap. And so that nerve impulse is able to jump across those myelin sheath areas over the node of Ranvier. And that's how a nerve impulse travels so rapidly. Again, remember, gray matter is going to be unmyelinated. That nerve impulse does not move as quickly because of that. And so your white matter, those ascending tracks, very, very quick as far as sensory information, and that should make a lot of sense. As we progress into looking at dermatomes, really think about dermatomes as where the spinal nerve innervates and how that translates to sensory and motor function and perception. And so as you can see, this area I've highlighted, we have C2 to C5. Always think about patient's ability to breathe. And we know the phrenic nerve innervates into that area of the neck. In most cases, you could say right around C3. But I think it's safe to say anywhere in between that C2 and C5, you likely could have, maybe not immediate, but you could have respiratory dysfunction and paralysis of the diaphragm. If we go all the way down, you can see even down into T2 to T4, we lose the sensation at the nipples. So really anything in the high thoracic up into our high cervical, if you lose the ability to have sensation at the nipple line, could that potentially interfere with intercostal muscle movement, patient's ability to take a breath based on those nerve impulses? So any high thoracic up into that high cervical is very, very significant. You're going to possibly see questions related to dermatomes and where likely you may see a loss of function, and that's essentially what we're talking about. If we go back to our case and we start looking at this patient, again, very flat affect. Vitals did not change much. Her systolic blood pressures stayed right around 98 to right around 104 systolic. Pulse rates stayed in the 60s. She didn't become bradycardic per se, but remember, she's 14 years old. A pulse is 60. She was an athlete. She was a soccer player. Very, very likely that is a normal heart rate. And we're going to talk about the perception of bradycardia and the perception of neurogenic and spinal shock, and really what we truly see in real life patients and how that contradicts maybe what you read in a textbook here in a little bit. From the paralysis standpoint, nothing changed. She had no ability to move her lower extremities, very, very mild or minimal ability to move her hands. She could make some form of an attempt to make a fist, but was really unable to do that. Very stoic, very quiet. She remained that way through the entire transport. So we will come back to her. I will show you her CT scan, obviously jumping ahead when we arrived at the hospital. And you can see here she had a significant injury from C3 all the way to C5. And that is a very ominous injury. She was obviously prepped for emergency surgery, and they did go in and stabilize that area into the C3 through C5 fusion. Now let's look at specifically the different areas of the spinal cord that can be injured, and then we'll relate that back to her and her case, and we'll look at assessment, ongoing assessment, medication choice, etc. as we move on. The first thing I want to point out and talk about is the anterior cord syndrome. And anterior cord syndrome, really, when you think about this, is going to be the most common presentation in a thrombus or embolus that affects that area of the spinal cord. And so this is not going to be a primary cause related to trauma, although you can have a hyperflexion injury in trauma that can cause an anterior cord syndrome. The likely cause of anterior cord syndrome is going to be a thrombus or embolus, or an aortic dissection, a AAA repair that then is not sufficient to perfuse that area of the spinal cord, and then that area obviously becomes damaged. When we look at anterior cord syndrome from the trauma standpoint, this slide really just shows us the difference between a hyperextension and hyperflexion injury. This is going to be that hyperflexion injury. Again, a lot of times is going to be related to a diving accident, could be related to, a fall. In comparison, we have hyperextension. And so these are likely the injuries that you're going to see for high cervical spine injuries. When we think of anterior cord syndrome from really the symptomatic side of these patients, we have to understand that the injury is going to be below T10. These patients are definitely going to have fecal and urinary incontinence. They're going to have what's called spastic paralysis, and this is a issue with skeletal muscle performance, essentially. So you have an increased tendon reflex activity. You have what's called hypertonia, and their muscles are going to be very stiff. They're going to be tight. They're going to have the sensation of pulling motion. Hypertonia, if we look at that from a high level, is going to be a condition where there's just too much muscle tone. And so you have too much muscle tone in the arms and legs. They become stiff and very difficult to move. And so spastic paralysis is really a fancy word for a lot of issues related to our muscle tone and ability related to those reflexes. And then you have a loss of pain, a loss of pressure, temperature, and crude touch at the level of the injury and below. So now let's look at central cord syndrome and really think about this patient that we're taking care of. All right, again, 14-year-old female, diving accident. What potential spinal cord injury from a secondary assessment could she be suffering from? Obviously, probably very high cervical spine. She has a loss at the nipple line and above. But let's look at that from a high level. Central cord syndrome really is that central area of the spinal cord. You're going to see this most often in a hyperextension injury. So remember back at our picture, that hyperextension is the head going backwards. And so you're going to see this in motor vehicle accidents. You'll see this in head-on accidents. You'll see this in diving accidents. Very, very common, probably the most common injury in a diving accident. You could see this in minor falls, usually in older individuals. When we think about this, I want you to always think about what's called the CAPE sign. And the CAPE sign is essentially a acronym that represents what's called upper motor neuron lesion, spastic paralysis, hyperreflexia, hypertonia. So again, upper motor neuron lesion, spastic paralysis we talked about, reflexes, so your reflexes are very exaggerated. Remember, hypertonia is that stiff, rigid sensation of the muscles. And when you think about upper motor neuron lesion, that's where you lose the loss of touch, crude touch, pain perception. All that stuff is gone. So how do we look at this from a standpoint of assessment? Oftentimes you'll see on exams where they'll say you have a greater level of paralysis in the upper extremities than lower extremities. But I want to really caution that is not always the case. That is not a definitive diagnosis. Central cord syndrome, you can have paralysis that affects the upper and lower equally, but I think it's a case-by-case thing. And one of the things that I have learned working with a few spinal cord injury patients is that no matter how much we know about a specific area of the spinal cord that is damaged, every spinal cord injury is different. There is not one single spinal cord injury patient out there that will have the exact same presentation or symptoms or long-term care needs. Everyone is different. Some patients will recover a lot of their function back, others will not. And so A lot of differences there. Now let's look at the posterior cord and look at the syndromes associated. When we think about the posterior cord and the syndromes, I found it very fascinating that one of the primary causes of posterior cord syndrome is syphilis. And so when you think about sexually transmitted infections that are severe enough that go maybe unnoticed, undiagnosed, to the point where it causes a damaging effect to the posterior part of the spinal cord, that is very, very severe. And there's cases like that every single year. So you're going to see really posterior cord syndrome is related more to infections, genetic disorders, and you can see that in multiple sclerosis as well. One of the areas that we see this in is what's called tabes dorsalis. This is for just a high optic view, a degeneration of the nerve impulses, nerve fibers in the dorsal columns of the spinal cord. And really that is an area that's important to carry information that helps maintain a person's sense of position. So where are they at? How are they sensing their position in relation to other things? From a genetic standpoint, we have what's called Friedreich's ataxia. And this is a rare inherited degenerative disease that's unfortunate. It starts in kids or teenagers and gradually worsens over time. Gives them this unsteady gait, very awkward movements. They lose the sense of sensation due to that nerve injury in those areas. And then obviously we can see this in MS patients in severe forms. As I said, posterior cord syndrome is primarily going to be a problem with infection or in those genetic areas. And so this is obviously a rare finding. They have a very poor ability to have proprioception, which is basically a continuous loop feedback of sensory receptors throughout our body and our nervous system. And when we think about sensory receptors that are located in our skin, our joints, our muscles, when we move, our brain senses the effort, the force it takes, how heavy something is, and the actions and positions that are reported based on that back to the brain. And so that is definitely messed up with posterior cord syndrome. You're going to have bilateral pain in both sides of the body, and inability again to have sensation of the vibration side, and then what's called discriminative touch. And so your fine discriminative touch, just light touch, is also going to be severely hindered. So again, posterior cord syndrome is very rare, not something you're going to see from a standpoint of trauma. Now let's talk about Brown-Séquard syndrome. This is something that we talk a lot about in critical care medicine. From just an advanced life support standpoint, though, this is definitely something that you can see in the field, and that is going to be really related to trauma again. And so I want you to think of Brown-Séquard syndrome as an ipsilateral cord lesion, ipsilateral. So as we can see here in this picture, we have one side of the spinal cord that is affected. The most common cause of Brown-Séquard syndrome is going to be a stabbing, a gunshot wound, or you can see this in somebody that has some type of spinal cord tumor. And so when you think about ipsilateral, really what we say is you have a reduce or loss of motor power on one side of the lesion. However, pain and temperature perception are preserved. And then you have an opposite on the other side of the body. So your body is basically split right down the middle. And your body is sensing two completely different sensory positions as far as, like I said, power motor versus pain and temperature. When you think about this, they're going to lose fine touch. You're going to lose the ability to understand proprioception, vibration again. As we said, this is an ipsilateral cord lesion. And so again, upper motor neuron lesion is going to be that hypertonia, that hyperreflexia, loss of that crude touch, etc. So when you think about contralateral loss of pain and temperature, that is not going to be really at the injury level. And that's the difference between this and the other spinal cord injuries or disease processes is this is going to be 1 to 2 seconds below the lesion level. So it's not going to be right at that same point. And that's another difference in Brown-Séquard syndrome. The next thing I want to point out and talk about is what's called squaria. Squaria stands for, it's just a big long abbreviation, spinal cord injury without radiograph abnormality. And really the term has been used in adult literature, but it's honestly controversial. The important thing to note here is this is usually a trauma situation. It's important for the physician, the transporting team, to identify any past evidence of degeneration of the area, any traumatic abnormality prior, to meet the definition of squaria. And so most adult patients, are going to have a thorough assessment to identify any past degenerative diseases. But the prognosis on these patients, if all that stuff is negative, is great. And what they'll do is they'll do a CT scan that's going to be negative, right? The patient is showing all the clinical signs of spinal cord injury, paralysis, etc., at the level of the injury, but there's nothing showing up on CT scan. They're going to do an MRI, and that is also negative. And so prognosis for these patients is excellent. And this is what we really call spinal shock, where these patients may have minute swelling, but there's no impingement on the spinal cord. There's no transection of the spinal cord, and it's not identifiable on imaging. Now let's talk about assessment. And one of the things I want to really point out is the difference between hot versus cold. We know in trauma assessment, patients, if they're hemorrhaging, if they're bleeding out, they're primarily going to be cold. And we know that hypothermia in trauma is part of that trauma diamond. But when we think about a hot patient, we've always associated those patients with spinal cord injuries or neurogenic shock. If you compare a teenager with an elderly patients are probably going to be on medications that blunt their ability to compensate, whereas a teenager is not. They're going to probably be healthy, no medications, nothing like that. But if you find an elderly patient that's potentially in a traumatic injury event that causes a spinal cord injury and they're warm and not cold, that is a red flag. A little bit harder to pick up on a teenager, but a great example is this patient, 14-year-old female, in a diving accident. She was wet when we got her. She was warm to the touch. So, is that something you're cluing in on? Another assessment to focus in on is ask the patients to attempt to lift their legs. A true spinal cord injury patient, again, is not going to be able to move their legs, lift their legs. If they can lift their legs, you've already ruled out a spinal cord injury. Obviously, you got to maintain this patient in an immobile state. And I know I'm not going to get into all that. We know that literature has changed on long spine boards and C-collars and all that stuff. And so go off your standard current guidelines and protocols in your area. I will also go to the extent on a trauma patient. If I am under the suspicion that they have a pelvic fracture of any kind, if I ask them to lift their legs up and they can lift one leg or the other, no problem, I know immediately they don't have a pelvic fracture. A true pelvic fracture, they're not going to be able to lift their legs up. They will not do that. Now let's look at spinal shock. Spinal shock we referenced in the previous slides. I related that to squaria. And so think about this as an acute spinal cord injury. They're going to lose voluntary reflexes at the level below the injury. It can last hours, days to months. These patients will eventually regain function. They may not regain all the function. They may still have some disability. Now let's compare that to neurogenic shock. And neurogenic shock, I want you to think about as a high cervical to high thoracic injury only. That's something that we often miss. We think every spinal cord injury patient is a neurogenic shock patient, and that is just not the case. This is going to be encompassing high C1. Obviously, the highest we can go down to T5. You're going to have a loss of vasomotor. You're going to have a complete loss of sympathetic tone below the level of the injury. And again, this is where you often will see the hypotension, the bradycardia, the inability to regulate their temperature. And the problem is that these patients can be pretty profoundly sick that hypotension, that bradycardia can last a long time. We're going to talk about treating that here in a few slides, but the focus should be on the initial assessment. And what I will say is that initial hypotension, that bradycardia that we read about all the time, that is not always the case. And I would say it's rarely the case. That is going to be more of a late onset, maybe a couple hours after the injury. It is not going to be an immediate onset. And I would say the younger the patient, probably the longer it's going to take for that to present. With that being said, let's talk about our pharmacology and what is the best choice for medications from a vasopressor or inopressor standpoint. For the longest time, we've had dopamine in the pre-hospital setting, and there are still protocols out there that I know of that use dopamine as a first-line vasopressor in a spinal cord neurogenic shock patient. So let's look at that. Really, the reason why we often focus our attention on dopamine in these neurogenic shock patients is the assumption that these patients are going to be bradycardic. Obviously, if we're losing sympathetic tone, now we're dominant parasympathetic tone, we have a high tendency to become bradycardic. Again, I want to caution you that that is usually a late onset. That is not going to be immediate, and in most cases, will not be seen in the initial care of the patient. When we think about dopamine again has been around a long time. It is a medication that still works, but I think from a standpoint of overall opinion, dopamine really should be the last choice. And the problem is dopamine, even though it is very common, we have definitely seen a big change in the industry over the last, I'd say 3 to 5 years, where more and more EMS agencies have moved away from dopamine and gone straight to Levophed or norepinephrine. We have to remember dopamine has a lot of side effects to it. And one of the problems with dopamine we have to realize is no matter if you're using a low dose or a higher dose, dopamine will increase diuresis and overall volume loss. And so that's something we really can't afford in a neurogenic shock patient. So that's one reason why we would stay away from dopamine. Higher dose dopamine leads to more arrhythmias, and that's another issue. And then when you get into doses greater than 10 mics per kilo per minute dopamine, we start seeing a dominant chronotropic effect. We lose the inotropy, and our patients become profoundly tachycardic. And then you're really losing the whole reason why you started them on a vasopressor, because now their cardiac output decreases because your ventricular filling and clearing time is depleted significantly. So what is a better choice? The best choice, really, from the opinions of the docs that I know and work with, is norepinephrine. And we've seen this really across all types of cases. Sepsis is the same thing. Norepinephrine is a great drug. And so let's talk about that. So when we think about this, remember norepinephrine stimulates those androgenic receptors. They're alpha specific. It's a better overall vasopressor. Does not have any diuresis. It's not going to cause arrhythmias. And remember, it does have some beta 1 stimulation. So you are going to see a little bit of a bump in that heart rate. Really, your treatment focus should be volume, fill with some fluids. Doesn't mean you need to give them 5 liters. I definitely, if you have it available, I'd probably go LR over any fluid at any time. If you don't carry LR, normal saline is fine, but I'd give them a couple liters of fluid, fill that tank, start that inopressor. I would definitely go with Levophed and target that MAP. When we think about a target for a MAP, spinal cord injury is no different. We actually need a higher MAP in spinal cord injury patients, and they do what's called a MAP push. But for purposes of us in the initial assessment and treatment of these patients, a MAP of 65 really should be your goal. You do not want a patient sitting there hypoperfused in a spinal cord injury situation. So don't be letting your patient sit there with a MAP of 40 or 50 if they are profoundly hypotensive initially. You've got to get that MAP up to that 65 target as a minimum. So what are some secondary considerations that we need to identify? We have to understand that taking care of patients, you may transport patients that are past spinal cord injury patients, And so there's a phenomenon that we need to understand called autonomic dysreflexia, or what we say is neurogenic bladder. And I'll touch on that in the next slide. But really, autonomic dysreflexia is a spinal cord injury problem at T6 and above. Really, they cannot feel any painful stimuli. So anything that causes pain to you and me that we could feel, it could be even pressure. It could be leaning up against the wheelchair in the wrong way. We talk about a case where there was a young teenage girl that their parents gave her some new shoes, put some new shoes on, didn't realize they were too small. Toes were kind of crunched in the toe of the foot, and that was causing pain that they did not recognize, right? She doesn't feel it. And that caused a sudden spike in that blood pressure. And so that is the key, is a sudden painful stimuli that is over a period of time that cannot be identified can cause a sudden spike in that blood pressure and cause a hypertensive crisis situation that can be potentially fatal in some cases. And then when you think about a neurogenic bladder is right along the same line, and that is based on Foley catheter kinks. If the patient is unable to evacuate urine, obviously lower spinal cord injury patients will self-cath themselves, and they can identify based on different stimuli that they've learned. They know when they have to go to the bathroom. But when you talk about these high spinal cord injury patients, T6 and above, they don't have that ability. And so if their urinary catheter becomes kinked, they can't drain their bladder. It will cause the same sensation as we talked about with autonomic dysreflexia, and you'll have these sudden spikes in blood pressure, these hypertensive crises, and again, this can lead to a fatal ending. In the end, guys, what we need to understand and focus on is spinal cord injuries are something that, in my view, one of the worst types of patients that you can ever encounter. I will tell you that this patient, this 14-year-old female patient, she ended up being really one of those miracle patients, and she's considered to be what's called a high-functioning quadriplegic. She has learned to walk again. She walks with a very unsteady gait. She has gained a lot of function back, but it was finally diagnosed in the ER that she was a central cord syndrome. Again, C3, C4, C5 crushed based on that hyperextension injury. She is now in her early 20s. I had this case back in 2012, and she's done some amazing things. She speaks about her recovery, but she still has consistent issues related to that injury. And so, even though she's regained a lot of function back, she still has a lot of problems. Again, I think the keys are understand your assessment, understand that there's definitely a difference between the textbook and what we see in true spinal cord injury patients. Don't be surprised if you don't see that bradycardia, that hypotension early on. I think it's going to depend on the length of transport, how long you're with this patient. But take care of what you know, get those IVs established, get volume on board, be prepared, understand the medicine. And if you have any questions related to this, please email me, eric.bauer@FlightBridgeED.com, and I will talk to you on the next one.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.